Good afternoon and welcome to the last session for today on use cases. So this last session will discuss how AI might be used in the public and private sectors and how economic incentives and societal implications of AI can interact. So we have four wonderful panelists for this session. I will call the first one to present at the lectern, Eric Sutherland, Senior Health Economist at the OECD.
Okay. Anyway, so interestingly, to the last question that we had in the last session, health, when Hippocrates meets AI, moving fast and doing no harm. And that is one of the things we have to do uniquely in health. Maybe not uniquely in health, but certainly is one of the challenges of trying to find a way of achieving that and between moving fast and doing no harm. Like we also have heard earlier today, we're hardly moving fast. We need to move faster, but we always are guided by doing no harm. So my intention in the next 10 minutes is to talk through very quickly a few of the reasons why there is such opportunity in health, what some of those rate limiting steps that we've heard about are in health, and what practically we can do about them. So all that said, we'll see if the slides are going to work today. Cool. So it may interest you to know that health makes up 30% of the world's data, the entire world's data, because genomics, various imaging, et cetera, that we have. And is growing, always happens. And it is growing faster than most other sectors. And health uses about 5% of its data. So if you do the math, health, we are not using collectively more than a quarter of the world's data assets. That feels pretty, negligent, inappropriate. We are not doing what we need to do. And so there is huge opportunity for us to mobilize our work, and this is why there is such efforts in the health sector to use AI, to use these data that we already have better in order to achieve the beneficial outcomes we have, both in terms of novel treatments around radiology. It's hard not to read articles about radiology, but also to find things that are more mundane. How can we save 1 minute per appointment that a doctor has through AI scribes? That is proven to be true. And that saves, on the order of 2 million minutes a year. That's pretty impressive. I would like a solution that saves 2 million minutes. Now, that doesn't turn into net outcomes necessarily, but it helps provide a better experience for the provider, allows them to spend more time directly focusing the patient, allows the patient not to see the back of a screen, but to actually see the provider's eyes, which is a novel concept, and improves overall quality of care, which leads towards better health outcomes in the long. That's one of the things we want to be doing. Now, normally when I'm giving these types of talks, I talk to people who are mostly health folks and talk about how we in health need to be more humble, because there are massive opportunities for health to learn from other sectors. I would submit there is better opportunity for us to learn across sectors. There are already industries that have been significantly disrupted through digitalization. We've heard about some of them earlier today, around airlines, around finance, around consumer goods. And so how can we learn from what they've done? Because one of the major ways that these industries have increased their productivity, they've increased their productivity and their effectiveness, and overall, by the way, health way lags all other industries in AI adoption and in productivity gains in the last 20 years. Why have they been successful? Well, one of the reasons is they treated the customer with respect. They treated the customer saying, we trust you to be a part of your own process. When was the last time any of you sat in front of a bank teller, sat in front of a travel agent? You ordered something on Amazon. Why? because all of those are cases where those organizations have pushed work to you, because you are the person who is best in the best position in place to achieve your outcome. So it's logical that they would want to push that work to you, but we don't do that in health. We think, oh no, it's too complex, it's too dangerous, we can't possibly do that. And this is what we heard before, scheduling. Scheduling is an obvious thing. I don't care I do care where I have my appointment, but make it easy for me. Find the solutions that are most effective for me to achieve my outcomes. I can do that myself with an AI. I don't need doctors and nurses and other people in the background doing the work. There are lots of things we can do where we can trust the public by pushing the work to them. And so there are big opportunities for us to think about that problem space, those AI-sized holes, about using the tools and technologies we have in order to improve the experience and the effectiveness and efficiency of our health systems by meaningfully embracing work with the people who are most incented to make sure it is done well, which is to say, the patient. Because honestly, we have not respected the patient in much of our work that we've done. So one of the reasons why we've done that, this is a bit of an eye chart. This is a process map for one innovator to get access to one data asset in the province of Ontario. This involved 9 organizations, over 100 steps, which could take about 18 months and cost the innovator $50,000. And with all those numbers, I ask you one question. How much innovation is happening in Ontario? 0. Not really, but really. This is the type of problems that we have because we have been doing digital work for 10, 20, 30 years. And we're really good at adding processes on top of processes to make sure that the controls are appropriate and in place. What we're really not good at is cutting. What we're not good at is rationalizing, oh, maybe we can do this in a more effective way. Maybe we should partner with each other. Because I will submit to you this, none of those 9 organizations are incented to improve care for the person, for the patient. All of those organizations are incented to protect the reputation of their organizations. And when they're doing legal agreements around, do I provide access to the data? Do I provide these services or not? They are protecting the reputation of their organizations. So what we did in this case, we said, no, somebody needs to be accountable for the end client. So in the province of Ontario, we said there needs to be a role on top of these 9 roles that help coordinate these activities and streamline these processes, because frankly, it is scary and is harming our ability to achieve our overall outcomes. We were able to reduce the process to 3 months, cost about $10,000, really easy. Because really, and this is the do no harm part, the problem that we have is we're so worried about doing harm, but in health that has been internalized as privacy risk. I don't know how many of you have dealt with data privacy officers. Probably many of you. Privacy is one form of data-related harm. There are 8 other forms of data-related harm in health. For example, yes, by providing access to my data, I may subject myself to a privacy risk, and the privacy risk may result in an insurance company finding out more about my history and raising my insurance rates. That's bad. We do not want that to happen. There's also the risk that you fail to share my data with somebody who then prescribes medication to me that interacts with other medications I have and has a very negligent and negative effect. Or you may not know about my medical history and that I've had 1 kidney removed on my left, and you may treat me inappropriately for my medical conditions because I've had my kidney removed. Or I may provide access to information, and they may use that information for mis or disinformation purposes. Again, other data-related harms. There's a number of them. My whole point here is that we need to shift our focus from the sole thought about by saying yes to this, what harm may be created, to being what harm may be created by saying no, or what harm may be created by saying yes. Having that 360-degree view, but also a longer time span view. Because the problem with privacy risk is it's often near term and immediate, and the impacts are felt immediately. Failing to provide data may not allow researchers to do research that can provide beneficial research to cure various illnesses or help cure my disease in the long run. So we have to think about that other dimension. But then the overall thing is we need to be thinking holistically around harms in terms of the likelihood of those harms occurring and the impact of those harms occurring, which is standard risk management 101, but we need to be bringing that culture into the health sector to think about that holistic view around harm. And when we're calibrating harm, we need to be thinking about the people who care most, the public. We need to be thinking about what are the things that they want. And full information. Wow, I don't know why it keeps on flipping. This is a slide I actually got from your National Data Guardian, Nicola Bryan, a few months ago, because I love what she's talking about in terms of how to meaningfully engage with the public to find out, as we're calibrating our processes, as we're understanding what harms people are willing to accept and take on, and how to calibrate some of these things. She said, listen, involve the public, give them choice. That's where we're at. When we are talking about consent-based models, or frankly, a lot of the things we've done, we are living in the lowest level of the tier, worrying about legal compliance and privacy protection. But we need to be thinking at a much higher order of things. This is where, in countries like France, for example, they have a specific citizen assembly for digital health. That citizen assembly gives direct advice to government around what the public in general wants to see within their digital constructs. More than half of the recommendations, they've given more than 70 recommendations to the French government, and more than half of those have been implemented into law. Then that public, they're able to go to the rest of the public and talk about why this is good, is why things have been calibrated in this way. So you're building the champions into your system, not the champions who are government bureaucrats, champions who are people like me. And that's one of the magical things about involving the public, especially in this AI revolution that we have going forward. And the last thing I want to talk about, because theoretically I'm an economist, who knew? I'm not really an economist, it just says so on a business card. But the other thing we need to think about is that we are horrible in health about competition. We love to compete with each other. I was in a situation living in Toronto where two hospitals were literally across the street from each other consciously chose to be on different technology platforms because they wanted to make it harder for them to exchange information with each other. That's negligence today. But that is where we were 10, 20 years ago. We need to be fostering co-opetition. How to cooperate on the things which are foundational, which largely, in my opinion, rest on your data foundations. Because as we heard earlier on, we need to keep on not only gathering data, but we need to be providing access to the data, using that data, and by gum, reusing that data. We need to be focusing on that foundation. And then with that foundation, we then can compete on whatever we're good at. This is what finance does. I can take money out of a bank machine anywhere in the world. So can you. I can book my tickets on any airline from pretty much any airport. Doesn't matter where I am, because all the airlines have agreed how to cooperate to make that easy, because they know it's more convenient for me, and then they compete on services. but health is still trying to compete on everything. And as a result, they have massive fragmentation, and that massive fragmentation causes harm because AI solutions are built in silos, piloted in silos, with no ability to scale and no incentives to scale. And this is where, from a policy perspective, what we need to start thinking about is how do we incentivize not the first pilot, the first innovation of something, first commercialization, but to think about the second time it is adopted, when it is scaled to something else. And that is what we need to start incentivizing significantly. So I have no idea how my time is, so I'm going to go with, in general, we need to be thinking about how to cooperate to compete. We need to be streamlining our processes. One of the best advices that I can give to anyone working in this space is draw your process maps, show how disgusting your process is today, and identify what the problems are, if I can say it, the rate limiting steps you have to making the progress you want. That's what you need to be focusing on. You need to focus about how to minimize harm while optimizing opportunity at the same time, involving the public in defining what those harms are that are unacceptable and what are acceptable, and how to deal with those things when they do occur. And incentivizing scale, because scale is the only way that health will realize the economies that it needs to across the overall health system. I'll give you one other statistic because, you know, I'm with the OECD. 17.5% of health systems costs, so almost 20% of health system costs, are related with diagnostic errors. What tool is good at diagnostic error, at finding diagnoses? Well, something that gets the right data and information to the right people at the right time. So if we invest in AI and we reduce diagnostic error in half, we can save our budgets 10%. That's pretty meaty. That is worth the journey. And that gives us a specific area to focus on that helps us achieve what we want in the long term. So I'll be interested in whatever questions you have.
Thank you, Eric. Our next speaker is Hannah-Beth Clark, AI Quality and Safety Principal at Oak National Academy.
Great. It's really nice to see you all. My name's Hannah-Beth Clark. I have been a teacher for the last 15 years, and I now work at Oak National Academy, leading on the quality and safety of our AI tools. And I'm going to give you a quite specific use case of AI in education, but hopefully with lots of sort of generalizable points to sort of the wider education world. So this is our purpose at Oak. We were started over the pandemic. We created 10,000 lessons that were accessible for pupils from home when they weren't able to go to school. Following that, we made all of those resources accessible for teachers to be able to download and use for free in the UK. They're all aligned to the national curriculum here and designed to sort of cover all of the topics there. We've got sort of three offerings. The first one is a really high quality curriculum that's available for teachers. We've got an interactive platform for pupils. And the reason I'm here today is we also have an AI lesson assistant called Isla. We're government funded and everything that we produce is open source. All of our code is you can freely access. It's all available on GitHub. And there's a real sort of sense of transparency because we want to make sure that we're supporting other organizations with also being able to innovate in this space. So I wanted to talk a little bit about why we should be encouraging teachers to be using AI and educators more generally. I think the first thing is probably the most obvious and the thing that's in the press the most is workload reduction. We've got a really huge number of teachers wanting to leave the profession because they don't have enough time in their day to be able to do everything they want to be able to do. And I think AI has got the potential to save lots of time in that space. There's also a question about how teachers are using their time, and I think this is the same across lots of professions, but are they using their time for the most effective things, and can we sort of take over some of the tasks that are taking them lots of time so they can spend more time with pupils? We've got a real sort of issue with expertise in the teaching profession. We've got lots of very young teachers joining the profession, which is great, but we don't necessarily have all of the resource to be able to support them in developing. often teachers teaching across lots of different subjects, particularly in primary, and might be outside of their expertise. And even when we get to secondary, you're maybe teaching across 2 or 3 different subjects, depending on sort of the teachers that you have in your school. And then finally, the ability to personalize content for pupils. That might be in a marking tool, being able to give personalized feedback. In our case, it's in a lesson planning tool, and being able to personalize the content that you're giving to pupils to make it really accessible for them. There are a few risks, I think, that come with sort of encouraging teachers to use AI. The first one is a digital divide. There's some crazy statistics about how many pupils actually have access to good sort of internet at home and a good device at home, but also in terms of schools. And there was a recent survey done which said I think around 40% of schools didn't have reliable Wi-Fi, which is a fairly sort of huge problem if we're thinking about implementing some of these systems. The second thing is decreased expertise. I think there's a real concern that if we're using AI to, for example, mark pupils' work, or we're using AI to plan pupils' lessons, we lose that expertise from the teacher. We know that large language models have got bias within them, and we're potentially perpetuating that bias by using AI in our sort of teaching and lesson planning. There's the environmental impact of all of these sort of uses of AI, and making sure that we're only using it where it's actually going to have a positive impact. There's a whole host of safety risks, particularly if you're designing things that are for use in the classroom, even more so if you're designing things that are for use with pupils. Our tool is designed for teachers, but I know that there's lots of other sort of innovation in the pupil space. We know that the content that's produced might be irrelevant. Our use case is very specifically sort of UK education. Lots of the EdTech products have been designed for the American market. It's a much bigger market than the British market. But I would say that the British market's probably close sort of behind as a second place. And for lots of other countries, the content will be even more irrelevant because there won't be the sort of funding put into those the development of tools for those countries. And finally, there's big data risks. I think this is a really different point for teachers. We haven't previously had to think in the same way about how we protect data. You're often using a quite closed system within school, and there's trust that data isn't going any further than that system. And now we're in a situation where you're able to upload things into AI tools. You're able to sort of provide those models with data. And I think we're a sort of precipice of there being some very dangerous sort of data breaches within that education space. I think one of those last summer for me was the use of AI to write reports, and lots of teachers very sort of innocently uploading their data into a sort of something like ChatGPT, and then asking it to generate a report for them, and not realizing that was a sort of massive data breach. And it's just something very different that we haven't had to necessarily think about with teaching previously. The final thing on that data risk is around copyrighted material. Sort of teachers have access to lots of content through fair handling in the UK. They can use bits of mark schemes, they can use exam questions, they can use bits from textbooks. But that sort of changes when we start thinking about using that in AI. And I think that isn't something that necessarily teachers are that confident with where the sort of line is drawn. So I wanted to talk a little bit about how we've addressed some of these challenges within ILA. Normally, I am speaking for a little bit longer. Let's see if I can make this play. Would you maybe be able to press play on the video? Let's see if it works. No, never mind. We'll see if it plays in a minute. So this is ILA. We launched in September last year. It's a lesson planning tool for teachers. It takes teachers through the process of co-planning a lesson together, and it allows them to personalise the content to their pupils and their specific sort of use case. And when you get to the end of producing your lesson, it then produces some useful exports for you. So it produces a slide deck that you can use in class. It produces quiz questions formatted into an actual quiz, so you're not copying and pasting it from one source into another. It makes a worksheet for you. It makes a lesson plan for you. All of that is sort of editable and adaptable for use in your classroom. It's totally free for teachers to use, so anyone can go on and use it. And it's taking content from our database of lessons that have been created by humans, meaning that hopefully the quality and accuracy is much better. So the things that we've sort of embedded into that, we've got a very detailed UK-specific prompt. We're having lots of conversations about how we break that prompt up to make it more efficient as we go forward. But it's giving very clear instructions about our specific use case, so that teachers aren't having to input that. We use this process of retrieval augmented generation, but also content anchoring to anchor to the, we've remade all of our resources following the pandemic, but we're anchoring to all of that national curriculum aligned content to make sure that the quality and accuracy is much better and to reduce some of the bias that exists within the large language model. We've built some additional safety guardrails. Again, I could talk about the additional safety guardrails for about an hour, but if you're interested in that specific part, probably one of the most unique things that we've done is build an independent asynchronous content moderation agent that looks at all of the content that's produced by Isla and classifies it based on a few different categories to decide whether it's appropriate or not. And finally, we've kept the teacher in the driving seat. And this for us was really important in terms of the expertise part of this. We know that lots of trainee teachers are going to be using this as a tool. They're going to go to that as their sort of first port of call for planning lessons. And we wanted to make sure that it was modelling to them a really sort of high quality process for doing that so that we were improving expertise rather than sort of decreasing them. We've gone through a number of stages of testing, how we're making sure that this is sort of safe and high quality. In the UK, they've sort of recently released, the DfE's recently released some safety expectations for AI products. The onus is on edtech companies to embed these, but it's not mandatory at the moment. It's sort of a guidance document. But we've taken those very seriously. The first thing that we do is we do lots of internal testing. We're very lucky at Oak to have subject leads for every single national curriculum subject who are experts in their field and sort of sitting within their teams a whole number of content creators, which means we're able to do very rigorous testing before we release anything. We've also built an auto-evaluation tool. This is an AI-powered tool that evaluates the content that's produced by Isla and sort of assesses it across 24 different benchmarks. And then those evaluations are tested by humans and checked by humans. If you're interested in that, we've written a paper with MIT Open Learning, which sort of goes into detail about the process. And finally, we're using lots of user feedback to sort of develop that and build that back in. I wanted to talk a little bit about the choices and the challenges for us and then for other organisations. I thought I'd start with, first of all, the choices. We've decided to make the tool totally free. All of our content and all of our code is open source. We've designed it intentionally for novice users. We know that lots of people are quite sort of worried about using AI and might choose not to use it if it isn't designed in that way. We were fortunate because we started from a position of reputational strength. Lots of people knew Oak from the pandemic. We had 1 in 3 teachers using Oak already. So we were already in a position where we had a sort of ready-made audience. And we chose to make it available to use on lots of different devices. We know that lots of teachers will use a laptop to plan lessons, but we know that they also might use a mobile phone. I think there are a few challenges for other organisations that are working in this space. The first one is alignment of curriculum across different regions and across different schools. In the UK, we have a national curriculum that's set out by the government and everyone follows the same curriculum. So we were able to produce a corpus of content that aligned to that. That's not the case for lots of other countries. So I think that's a challenge for other places. We also had a really high quality bank of underlying content that we'd made as part of our human created lessons. The most useful of those is actually the video transcripts of an expert teacher delivering each of those lessons. But I think that's a challenge for others looking to build a similar tool, is how do you get that high quality corpus of underlying content? We know that large language models are fairly good in English, but not so good in other sort of languages. And I think that's a challenge if you're working in education in a different country or in a different sector in a different country. The availability of technology, I think, is something to consider. In the UK, we've got fairly good access to technology in schools, but that's definitely not the case everywhere. And then finally, guidance on safe use. As I said, the DfE has only really recently released guidance on the guardrails that we should be putting in place for AI tools, but that's definitely not the case across the world, and it's definitely not sort of been agreed on across the world. And I think there's lots of sort of grey areas for educators in terms of what it can be used for, what it shouldn't be used for, and the additional safety guardrails that we should be putting in place. That's like a very rapid tour to Isla. If you've got more questions, I'm going to be around afterwards, and then my contact details are just up at the end.
Thank you, Hannah-Beth. The next speaker is Jessica Montgomery, Director of AI at CAM at the University of Cambridge.
Thank you. Hi, everybody. Now, in a remarkable feat of being on message, some of this talk will already be familiar to you from Neil's talk this morning. It's rooted in work by AI at CAM, which is Cambridge University's mission for AI that serves science, citizens and society, but really focusing in on the work that we've been doing with local government partners within Cambridgeshire and in the Northwest on the use of AI in public services. Okay, so some key messages to start. Earlier this year, we heard from Prime Minister Keir Starmer that UK government was going to start injecting AI into our veins. Well, at that point, actually, we'd already seen a range of examples of innovative uses of AI in local government that in some ways were ahead of the thinking in central government in terms of how to create value from new AI applications. So there are already real-world examples from UK councils that show how AI can improve service delivery and that give us a pathway for innovating with AI from the ground up. So picking up our discussion earlier about, are there spaces where people are just able to get on with things and try some things and scale what works? Yes, we're already seeing some of that here. Secondly, we see time and time again that public expectations emphasize human-centered AI with democratic oversight, and we need to do better at delivering on those expectations. And then thirdly, we know that successful implementation requires user-led design and cross-organizational collaboration that's really starting with business need, that's cutting through that AI hype and refocusing on what is our business, who do we serve, and how do we serve them. Again, things we've known for a long time, but this latest wave of excitement about AI really prompts us to go back to basics in that regard. Okay, so what do we hear from our partners in local government about why they are turning to AI? Well, it won't be a surprise to anybody in this room that a lot of these partners are facing intense resource constraints at a time of growing service demand. So they're looking for productivity improvements. They're looking for service efficiencies that are both about saving time and about delivering services better. They're looking for cost savings, and they're looking to improve resident experiences. Across all of the councils we work with, a primary consideration is how are we serving our community and how are we doing better for the people that interact with us? We're already seeing a range of different application areas across different government bodies. So there are 6 examples here that I'll talk through briefly. Firstly, contact centres. This is something pretty much universally shared across the local councils we're working with. People are looking for AI tools that can either allow users to self-serve through contact centres, so answer their own questions, or that can improve the process of triaging questions to areas of need. And we worked with collaborators in South Cambridgeshire District Council on the rollout of their AI-enabled contact centre service. And what they will talk about is being faced with a range of different companies that are looking to sell them solutions, that are telling them we have the tool that will fix your contact center problem. But what they did is they started by going back to their own data and their own understanding of who is using their contact center and for what purpose. This project started with a deep dive of who are we interacting with and what questions are they asking us, before moving on to what does that mean for how we'll interact with AI. So they've been taking a phased rollout to a system that starts with a text-based tool and is now moving on to a voice-based tool. And one of the key features of that tool has been the feedback loops they have with their users as they're rolling out that implementation. And to give an example of what I mean by that feedback loop, they rolled out the first iteration of the tool, which was about getting users to self-serve. And if you couldn't self-serve, you were directed to a longer queue to interact with a human. One caller called up wanting to talk about the death of her husband and reporting that death and wanting to update the records that the council held. She was put in a queue. And her feedback was, I know my query won't come up all that often, but this is somewhere where I should not have been put in a queue. I should have been able to talk to a person, because that is such a deeply personal experience. I'm somebody that is already going through a difficult time. Shouldn't the council be looking after my well-being in that situation? How were you looking after my well-being in that situation? And as a result of that, the council has taken that feedback on board and adjusted the tool accordingly, so that those types of keywords now trigger a different pathway or a different user journey. But that type of feedback loop is vital in this type of application. So if we go to planning, this is an area of intense hope from government that AI might do something to help unlock progress in the planning system. And actually, we have some brilliant indications from a local project about how AI might help with local planning. So if we think about local plan consultations, the last local plan consultation in Cambridge generated over 19,000 responses. As Neil was saying earlier, it took over a year of person time to analyse. A collaboration between Greater Cambridge Shared Planning, the University of Liverpool and the University of Cambridge and Anglia Ruskin University is developing a large language model that is helping automate the analysis of those consultation responses. The idea is it can go from over a year of person time to analyse those responses to under 2 months. That's a radical shift in the amount of resource required just to process a bulk volume of information. But again, there we know that we can't just rely on LLMs to capture all the information that we're putting in accurately. So these feedback loops are crucial. And one of the feedback loops that the team is implementing is that after you've uploaded your consultation response, you immediately get a summary, a short summary of what the LLM analyzes that you have said or what your priority issues are. So as a user, you can check that and feed back on whether or not the right types of messages are being captured. Thirdly, when we think about housing stock, we heard about an innovative project from Greenwich City Council, which was about triaging maintenance requests. So looking across their housing stock and asking which houses do we need to repair as a priority in the context of massive demand for management of that stock. And really one of the lessons from that project was that AI can be a catalyst for going back and fixing some of the fundamental data problems we have in local government or in public services. Because, okay, they've developed an AI tool that is helping do that triage and helping match those needs. But really what that project allowed them to do was go back and fill in holes in their data resources that have existed for a long time, but have lacked investment. And they haven't been able to previously make the investment case for fixing those data holes. Social care is an area where we're seeing a lot of applications of automated note-taking apps. So we're hearing, for example, from Wigan Council and from Peterborough City Council about how social care workers are using off-the-shelf AI tools to automatically transcribe notes from interviews they are having with service users, and how that process of automatic transcription is allowing their social care workers to go from seeing maybe 5 patients a day to 10. That's a huge productivity improvement in terms of the ability of those social care workers to spend time really on meaningful human interaction rather than note-taking, and on how we can ease administrative burdens in an area of massive social need. We're seeing a lot of sort of back office administrative uses in terms of minutes and note taking and so on. Again, also hearing those concerns we heard about earlier in terms of how do we train the next generation of workers if they are not themselves producing minutes, writing agendas. How are we training those people to really understand the purpose of public administration and the purpose of things like minute taking? And then we're seeing a range of interesting applications in transport, but locally in Cambridge, range from the prospect of autonomous buses on the streets by the end of this year to the use of AI for traffic analysis. And again, here we see really interesting flashpoints between service users and people delivering AI services. For example, there are some traffic cameras in Cambridge that are making use of AI to analyse data about traffic flows. This came out in the local papers. There was at the time one junction where AI was being used to improve traffic flows. As a result of that being announced in the local paper, a series of junctions and traffic cameras were vandalised in the belief that those must be the AI services, showing the type of public reaction to applications of AI that impinge on our daily lives and experiences, and the perils of forgetting that all of these services impinge on the things we value and the things that matter to us as individuals and as communities. So on that note, what are we looking for as individuals and as communities? We started this conversation at the start of the day with some of Neil's comments about the results of public dialogues over the last 10 years, which have been incredibly consistent. People tell us repeatedly what they want from the development of AI. that they want human-centered systems that enhance our interactions with each other and our interactions as a community. They want systems that reflect concerns about fairness, equity, and awareness of biases in AI development. They want clear governance and accountability around the use of AI. They want transparency about how and why AI is used. They want the ability to raise concerns and appeal decisions, and they want a voice in AI governance. All of this is incredibly consistent over 10 years. These themes come up time and time again. What might be coming up more now, anecdotally, is sort of a skepticism about the value of AI. So whereas 10 years ago, when Natasha and I were leading the first UK dialogue on machine learning, people were coming with an open mind. They had questions about who benefits, who bears the risks, what governance systems can we create, but they saw both benefits and risks in a whole range of different application areas, with the exception of creativity. Now it feels like people are coming to the table with a much stronger skepticism about AI, with a feeling that AI is something that is being done to us as communities, that is not something where we have a voice in shaping the future, but is something where we need stronger enforcement mechanisms or regulatory mechanisms to push back against the power of big tech in driving an AI agenda. It's sort of coming through from a couple of different dialogues, but there's data issues in drawing that conclusion firmly. Okay, so where does that leave us in terms of implementation considerations for AI in the public sector? Well, we're back to the fundamentals. We are back to user-centered design that starts with a clear problem definition that relates to the people that are interacting with those services. It leaves us with fixing a data infrastructure that is still in a state where there might be records held on paper, records held in different formats, records held by different data owners in different systems, and when there aren't necessarily the incentives to share data, as we heard just before. It leaves us with inclusion as a fundamental requirement that needs to be delivered by design. And as we heard in Hannah-Beth's talk, people don't necessarily understand the depths of digital exclusion that we see today. So we had a conversation recently about why are there notices still posted on public lampposts about planning changes or local regulatory changes? And the answer is because those are people's touch points with their local community. In an environment where not everybody has access to Wi-Fi or high-speed broadband, where not everybody has smartphones, where even when they do, they are not necessarily going and looking for a notice of a change to fisheries regulations. That's one from my hometown. Those are the touch points, the real physical touch points that people have that need to be taken into account in service design. On ethics and governance, we are still struggling with how to translate ethical principles and policy frameworks into practice. We've been talking about the need to go from principles to practice since at least 2017 or 2018. That is a long-term hard problem. And what we need is spaces where people are going to be able to come together and work that problem from different angles, recognizing that there are no clear answers off the shelf. And what we need is people with real domain expertise to be leading that conversation. Again, we need a range of different skills and capability building activities, from an understanding of the potential of AI at senior leadership level to an understanding of how to work with AI in practice. And then we face a range of issues when it comes to procurement and the question of when to build, buy or partner on the development of AI. Again, as Neil alluded to earlier, we see fundamental questions there about who has access to data and when, and what type of value can be extracted from that data by different parties. Okay, so where does that lead us? This is a brief recap of the different messages from this talk. So firstly, that a lot of innovation is already happening at local level, that people are clear that they want human-centered AI that is enhancing our interactions and that is embedding democratic engagement by design, and that the most effective AI deployments start with business needs rather than technology push. They benefit from knowledge sharing across local authorities, and that knowledge sharing is really the route to accelerating learning and to overcoming those resource constraints. This is the attention reinvestment cycle that Neil was talking about at the start of the day. It's saying in a context where we don't have massive financial resources to put into this area of work, but we do benefit from strong human capital, can we better leverage that capital to drive innovation? Can we create a culture where, yes, we have the fantastic first innovators, but we have the fantastic first followers who are able to take that innovation and scale access to it. And really what this work has been showing is that community will be our strategy for scale here. If we can encourage people to take ownership of these tools, to figure out what works in their business area, but then plug that expertise they have back into building a community of practice, that's the way we can see scaling of this innovation and wider benefit to both local authorities and the communities they serve. So thank you very much and looking forward to the discussion.
Jessica, and our last speaker is Kristin-Anne Rutter, Executive Director at Cambridge University Health Partners.
Good afternoon. Well, we're bookending this session with health, which of course I'm very happy about because I think it's an area where there is both huge opportunities but also need for AI. As you've heard, I lead Cambridge University Health Partners, but I think what I'm bringing to this talk is three things. One, I trained as a doctor a long time ago. Secondly, actually, I've recently led a review on behalf of NHS England looking at technologies of the future and how they can transform health. And finally, I am tackling the challenge currently of trying to integrate data across 7 hospitals, 6 ICBs and social care settings across the east of England for 7 million people and bring that into the UK Health Data Service. So I'll touch on a few things as I go through. So back to that review that we led. We did a huge, as you could imagine, scanning of the technological landscape. We had partners from academia, industry and consultancy. But rather than concluding what were going to be the technologies that were going to change the future, we worked backwards. And this goes back to what we've heard all throughout this day about the importance of purposeful AI, as Natasha was referring to it. What are we trying to do with these technologies? Not what can the technology do? And in health, we concluded that there were 4 things. The first was to detect diseases and intervene sooner, allowing earlier, shorter treatments, better survival rates, and less work days to the economy. The best known example is probably familiar to you all in cancer, where 80% of patients will survive 10 years if detected in stage 1 or 2, but survival plummets to 25% if you detect cancer in the later stages of diseases. The second area is the personalisation of care. And I mean, that starts with what Eric was saying, with reducing errors. Don't give someone a drug that they're allergic to. But as we see further on, personalisation of care is going to get much more precise. We're going to be able to target care based on our genetics. We're already seeing that with cancer vaccines that are targeted to your personal cancer. You're going to be able to have hips printed on site for you based on your particular shape of your hip or knee. You might even have your genes edited eventually. So the personalization of care is the second shift, again, with the aim of improving outcomes. The third is reducing the need and time for human beings in the running and delivery of healthcare. Effectively, that productivity question that has run throughout the day. But spending on health is at a record high, and yet trajectories show that by 2030, we're going to be short of approximately 50 million healthcare workers globally. And already there's 1 in 10 vacancies in nursing. So finding a way to support those humans to do their jobs is going to be key. And the final shift is accelerating the pace and reducing the cost of therapeutic and diagnostic development. So how can we get treatments and diagnosis cheaper and faster, more readily accessible out the world? So those are the 4 areas. And AI is one of the technologies that's going to support that. As I said, there's going to be others like 3D printing, vaccine development, etc. But you could, if I had to pick one technology, it is probably the dominant technology across all of those shifts. Why is that? How is AI going to help? It should, I presume to this audience, be obvious, but the early detection and intervention of disease, that's going to require AI to support data integration to start with. Data integration ranging from your search history of what you happen to be looking up on Google, to your DNA, to what your activities are, to what your parents did and were exposed to. it needs to combine data that's collected over time. And then you need the AI to spot the trends in that data, the minuscule patterns, and identify that something is happening that a human can't necessarily detect. One of our researchers locally who's looking to do that is Dr. Anna Moore, and she's looking at how to use AI-driven tools to revolutionize mental health treatments for young people. How do we pick up young people who are going to be challenged by mental health issues to the point of incapacitation? And that is requiring her to look at data across social care, education, search histories, as well as healthcare, and join the dots to really try and see, can we pick up these children earlier? That second shift, the personalisation of care, then needs you to combine all that data with matching what's the most appropriate intervention, scanning all the literature papers, understanding the drugs, understanding the different mental healths. Are you going to be receptive to cognitive behavioural therapy? What's going to work for you? Is it going to be a weight loss drug, or are you going to need something else on the side? So you've got a double whammy then if you want to personalize the treatments of using AI to combine the data about you with the data out there about what the interventions are available. The third shift is automation. And the reason, actually, you could say, well, this is AI, this is replacing the human with artificial intelligence. But I think that goes back down to your doing the laundry analogy, in that it's not just AI. We're going to need really good robotics as well, because actually a lot of tasks on health require robotics, as does your laundry on top of the AI. So that's why I've used the term automation rather than pure AI, but it is going to need an awful lot of data to support it. And as we'll come on to, probably data in areas that we're not necessarily thinking of in the moment. There's huge opportunities in health. Again, Eric, you touched on some of these around scheduling, not just around scheduling of appointments, but optimizing flows of ambulances, optimizing capacity across the health systems, etc. So that all sits in that third bucket of reducing the need and time for the human being. And in bringing new diagnostics and treatment, the impact here is huge. We've heard about AlphaFold earlier on, but I wanted to provide another example in addition to that, which is 65% of the time to develop a new drug is actually in the clinical trials phase. And those clinical trials can cost up to £1 billion. And actually 40% of the cost is just on identifying and then recruiting the right patients into those trials. Surely a job well suited to AI. But we can take it further and be a little bit more exciting. We've got a scientist in Cambridge at the moment with Richard Gilbertson, the Cancer Institute, looking to create effectively digital twins to allow us to maybe not need to do human trials. We've got children that are going to grow up and develop cancer, and that we might then be able to test some of these drugs and approaches outside of a clinical trial. So harnessing AI to enable these shifts is going to be essential if we want to fix broken healthcare systems that around the world are struggling with worsening outcomes, higher inequalities, and unaffordability. But if the technology is going to help, we need to think about what it's trying to achieve. And in order that we understand all those diffusion questions of the last session, I think if we focus on one of those 4 outcomes, we'll get the system changes as well. We've also heard of some of the challenges, though, of delivering these shifts through AI. Currently, I would say that we are not seeing the development and implementation of AI in the areas of greatest need. A lot of this comes down, I think, to the availability of data. So you're seeing AI where the data exists. So we're seeing AI, it's not bad, we're seeing AI in radiological image interpretation, where we've got really good data. We're seeing it in digital pathology. We're not seeing it, again, a bit like an example of that elderly person who comes into A&E, 10% of A&E attendances off their feet. Effectively means they're just can't start, they're frail, they're out. That goes back to your Chris Whitty example. But for that, we don't actually have the data, and we're not collecting the data from their home, from their healthcare records to predict and understand what that need is going to be. Similarly, we're not really focusing on collecting the data around capacities planning and scheduling, etc. So we're not seeing the development and implementation of AI in the areas of greatest need because we're not starting needs back. The second thing, as has already been identified, is progress is lagging behind in health compared to other aspects of society. And the third is that I think it comes back to an audience question earlier, that again, it's linked to the data. Given the set of data and care and the way care is configured currently, AI is probably on a trajectory currently to worsen healthcare inequalities, at least in the short term, rather than improve them. If you just think about the simple aspect of what data is trained on, 94% of data in UK Biobank is white, for example, as a very simple explanation of this. And if you look at the uptake of many people have had in the UK will have had an invitation to participate in Our Future Health, which again has, despite efforts, it's going through a lot of efforts to recruit diverse particles, has a biased uptake in who has responded to that. So for this audience in the room, where do we prioritise research and policy making? One of the questions for today, to overcome some of these challenges. And I would say a lot of what we've heard earlier about the adoption of innovation came up in the review that I led. You need the right incentives, you need the right leadership, you need the right skills, you need to involve people, you need to start business back. But the three that came across really strongly for AI in the review was the data, the regulation, and the business models. So just to say a little bit more about each of those three, but then effectively hand it open to policymakers to do the work in those areas so that we can get better in them. The first is access to data. We've already, that's been well covered, so I'm not going to go into it, but knowing what data, how to combine, what to combine, ownership, how to build public trust. We've been talking about this for a long time, actually, as Jess has reminded me on several occasions, particularly in health and how to put healthcare data together. But actually, AI gives a renewed impetus for it. So I'm going to take it and say that takes us back to the data question. Secondly is regulation, so that we can do what Eric said and not do harm. Regulation is important. I would add guidance to that, because I also get reminded by regulators that it's not all about what is actually in law, it's about the adoption, the guidance. And healthcare is risk averse, and it does have this do no harm mantra. And it also has a really, and the way it thinks about that is a bit like, how do we make sure before we let anything out into the world of healthcare that it is as safe as we can possibly make it? So it's a bit like trying to make sure before you're given your driving license, you've been trained on every type of road, in every type of environment, under every possible scenario. You've done it for 6 times, you've raced against a racing car driver, and we want to make sure it's as perfect as we possibly can get it. It's similarly for training doctors and getting them to consultant level. And by the way, once we let you out, you're pretty much free. You don't have your driving test revoked. You do have a little bit of quality, but it's not once a drug's out there, really bad safety concerns, but it's out there and it's free. So we've got this system where we try and get it, and that's not very well suited to AI, because in AI, actually, you want to get it out there, you want it to know, you want to monitor it. So we need to adopt our regulation and policy, our whole approach to how we manage innovation, to allow us that sort of more shifts to giving something a provisional driving license and monitoring it very closely and helping it to learn and to revive it. So that's quite a shift in the whole way healthcare is regulated. And the final point that I think work needs to be done on, again, it's been touched on, is the business model. Paul talked about the business model for AI. Diane, you commented on the business model, the challenges that the gaming industry, the architects found about people then not valuing the gaming technology versus the issue because they didn't see the value in it. And I think we have a real challenge about business models. It's interesting to hear that you've made everything free. That's funded by the government and things. But I think that if I just think about the problem of data, for example, forget the business model for AI, I think the data, if we do need to generate new data that, like the data that trained the AlphaFold models, how are we going to do that without, or at least bring together and match the 60% of data that's not used so that it is usable? That's going to take quite a lot of investment. And in a lot of places, the data is sort of given for an immediate benefit and clean for an immediate benefit. We give data, Facebook, we get something back, etc. So there's a business model for it. That sort of business model doesn't really exist in health. They tried it with 23andMe, in that you give your data and you get an immediate feedback on how good at sport you are and potential inheritance. But even that has slightly fallen down and has not been sustainable. There's a lot of money here that's required. At the same time, there's a sense that we want it all to be open access and open source. So what's the balance between those two things of how we have the incentives for people to invest, 'cause it is going to take investment, so that they do can see some form of return, but that it doesn't end up in big monopolies, as it was said. So I think it's unrealistic to think that governments and philanthropists will fill this gap fully. So I do think we need to find a good way of creating a business model to do this. But on that note, I will finish on an optimistic note that the UK government has just announced further investment in UK healthcare data with the Healthcare Data Research Service. I also like the fact that it's called a service rather than access to data, with the aim of making that data available. So hopefully that will take us one more step on here in the UK. It's very exciting that they've joined forces with Wellcome to do this. Someone who's very good at handling large volumes of data. There's the potential that the centre will be based here in Cambridge. But again, it won't solve, having the data technically will not solve the problems of getting AI adopted. That's down to the people in this room. And potentially maybe we can take that further and use an Airbus model for data across Europe, but that might be stretching it. So I'll leave it there. Thank you.
Thank you, Kristin. I will now invite all the speakers to join me on stage for the discussion. And before I open the floor for questions from the audience, I'll just perhaps ask you one question. You all made the case for AI use in your respective areas, and this gives the impression of a massive untapped potential of productivity and quality improvements. So what are, according to you, the main barriers to a wider and perhaps a wiser adoption of AI, and how to overcome these barriers? Who wants to start? Eric?
I'll be brave. So technology is easy. The hard part is around the data, but the really hard part are people. It's how do we find the culture and how do we operationalize a culture that enables the AI to be integrated and adopted and accepted and wanted by the people who are going to be impacted. So I think it's really around finding those champions who are willing to make sure that the answer is yes. Now let's find out how to get there. Because frankly, in many cases, we're surrounded by no. So how do we find the champions who say yes?
I think in education, it's probably like the sense of being overwhelmed by choice. I think there's lots of different tools and products available, and I think it's really challenging for teachers to have, or leaders in schools to have the headspace to be able to work out what's actually going to be effective in schools and what's going to be, safe to implement and high quality. And I think some way of us enabling that decision to be easier for school leaders to make would sort of increase the adoption.
So we're at risk of being in violent agreement as the panel goes on. But yeah, we're talking about a whole range of different technical, legal, organizational, cultural barriers to adoption in a technology area that is itself fast moving and entwined with a whole range of different social and ethical concerns. And so I was struck by, I think it was a point Alex made earlier about, can we stop talking about sandboxes and innovation spaces and start doing some of that, giving people the space to innovate, giving people the resources to innovate in a way that is led by business need and by user need, and giving them the kind of political cover and leadership to say, we embrace that innovation. We're going to create a space where you can fail safely, and we're going to support you to scale the innovations that work in practice.
Yeah, and I think the only thing I'd add to all of that is that in health, people are not incentivized actually by outcomes and to do the right thing. They're not measured on healthcare outcomes. They're not measured necessarily on the productivity of their system. They are measured on the done something wrong or out of the crowd. So actually the basic fundamentals in how we judge our healthcare system are not aligned to the adoption of innovation and the adoption of AI, and therefore the space isn't created to do exactly what you said, Jess.
Thank you. Sorry, I have my own microphones. So I will now open the floor for questions from the audience or online. Yes, there is a question there.
Thanks. Tanya Goodin from Ethic AI. Jess, I was really struck by your reference to those vandalized traffic cameras. And I think public trust has been touched upon by lots of people throughout today. But I wondered if the panel had any thoughts about what we can do around improving public trust in AI, because there is a definite tech lash against AI being done to the public. And when we're talking about barriers for adoption, it strikes me that the trust from the users is one of the biggest barriers. So what are any of your thoughts about how we can deal with that?
I'll kick off there. I mean, the first point, and it sounds trite, but it's really difficult, is to make AI useful for people. Actually make AI systems where people feel the tangible benefits to them, their daily life, their family, their community. And then secondly, we've had a lot of these public dialogue, public engagement exercises over the last 10 years, as I've said. What we've never really been able to do is meaningfully connect those in a sustained way, either to where R&D happens or to how policy happens. And that's something that we're really passionate about trying to fix in AI at CAM.
Any experience from the education sector?
I was going to say, I think for us, it's been about transparency. I think there's a real sort of fear about AI and about where AI is being used and what it's being used for and how it's being used. And I think a real lack of understanding because of time and sort of being able to invest time in really understanding how those things are happening. And so I think for us, it's been about being really transparent and explaining in really simple, sort of easy to understand language where we're using AI and why we're using it and how we're using it, and then being really upfront about the fact that it's not going to be a perfect solution. And that's probably a little bit different in education than it is in health, I would imagine. But in education, sort of stating that upfront and saying this is something that's going to get you 90% of the way, and then you're going to have to use 10% is going to be on you, I think has really helped with sort of adoption of that and confidence with that.
And it's not directly related to AI, but it's one of the things we recently did a survey of like 100,000 patients around the world. And one of the things that they said is that they lose trust in a system that they know is digitalized when patients continue to need to repeat the same thing. And they also say patients who lose trust in the health system achieve worse health outcomes. So there is real incentive for us to get our simple stuff together, because part of the problem that we have is that we don't get the simple stuff right. And that's where, riffing off what you were saying, that how do we make things just useful? And how do we be loud about the fact that we've innovated this? By the way, we use AI, but frankly, AI is just a stethoscope. They don't really care what it was. They just want it to be better for them and just continuously show that things are better and improving through these various innovations and get the simple stuff right.
Any questions? Yes, here.
Thanks. I really enjoyed the panel and the focus on use cases that actually matter to people. I really liked that lens, as I mentioned earlier. I just wondered what the panel's views are on how this connects to some of the political macro issues we were discussing earlier, particularly around market power and concentration of the sector, and how that might impinge on, the ability of those more people-centered solutions that you've all talked about when it comes to the surface. My worry would be that in the context of very dominant firms that are aggressively selling these technologies into public sector, particularly in a fiscally straitened context where there's a need to find cost savings, we're more likely to see AI solutions kind of imposed from the top down, right, rather than implemented in a more thoughtful way that people set out. So I'd be curious to hear whether you think those fears are warranted, and also whether there are any areas you think AI could be excluded in the sectors and domains that you work in.
I might just start two reflections on that. One, I think it probably does come down to, I think there is going to have to be some thought to how we protect data, not just copyright data, but healthcare data, etc. The other interesting statistic, for example, is UK Biobank, a very well-used UK. I think the number of patents, sort of 95% of, somewhere between 90 and 95% of sort of patents and innovations that have come out of that data are actually non-UK. Now, again, that's not a problem in such. They've led to innovations. That's great. But again, if there's not a business model where some of that flows back into the creation of that data and things like that, and how do we keep control of some of the data, particularly where it's been publicly invested in, that's one aspect of it. I think the other thing comes back to my provisional driving license. So there's a real, you were talking about the digital scribe. There's a big push nationally in the UK now to get digital scribes in hospital, and yet we've got healthcare researchers in this environment, actually, the Health Foundation saying, hang on a minute, we don't really know how to implement these things. So actually, can we just hold off, and we need to do research, and we need to, and that's not going to happen. We're not going to be able to stop that wave of let's have the scribe come in, but how do we sort of do the research in the real world and learn from it and get it reapplied and readjusted? So I think we need a different lens on this, that we're going to have to research things in the real world and make adjustments as we go along, is my reflection.
Want to react on this?
Yeah, so there's been this narrative developed, certainly in the last 3 or 4 years in UK policy, that big tech is the only place with the answers. Big tech has a lot of expertise, and obviously it's right for policymakers to tap into that expertise. But the extent to which we've surrendered the idea that anybody else has valuable insights is really a marked shift in the last couple of years of AI policy conversation. It's a fantastic trick that only the frontier AI labs really understand what's going on with this technology. And by the way, now buy all of our products and services because we're really the only people that know what we're doing. We need to shift that around. We need to build confidence again in our policymakers that actually there is a whole range of different types of expertise, including, most importantly, from the people who are working on the front line of these services, and put that expertise back in the driving seat, whilst building our capability and actually bringing together a more diverse community of voices and perspectives as we're developing these policy responses and these ideas for applications.
And another question at the center of the room here.
And my question is more about from Jess about the digital exclusion, especially among the older citizens, as local authorities use more AI, as we suggested, for the AI citizen inquiries. How can we make sure that we are not leaving behind the aging population and the people who have difficult to use AI? And how do we keep the right balance between AI efficiency and the human touch that we often need in the inquiries in public, like a facing service?
The practical thing that comes through in our conversation with local authorities is always having an alternative. So while they might be talking about digital first, it is not digital only. But more fundamentally there's just the process that I think Hannah-Beth was talking about of building awareness of the extent of digital exclusion. So, not everybody has a smartphone, not everybody has the ability to access these services. And even when they do, not everybody is relating AI to their day-to-day experiences. It can feel very distant. So actually having that conversation in a more inclusive way, where I think public dialogue plays a really important role in bringing a wider set of voices to the table, having that conversation and continuing to have that conversation with the people directly affected by services is vital.
I just add to that, there are some new roles opportunities that get created through this, because, for example, some countries have what are digital nurses. So they are people who are specifically designated to be the digital, so to speak, Sherpa for the aging people, so they can take advantage of the digital technologies, but they don't have to engage with the digital technologies themselves. And that could be for people aging, could be people with problems with fine motor control, or any number of things. So it's where the opportunity space, as much as we say digital disruption is going to change jobs, there are new jobs that get created through opportunities such as this.
School perspective, I think there's also I think there's sort of schools on different ends of the spectrum at the moment, and some schools are sort of wholeheartedly embracing AI and teaching pupils how to use it, and some schools are terrified of it and sort of denying all knowledge. And I think the risk definitely down at this end is that pupils are still exposed to it. I was in a school a few weeks ago and we asked 11 to 16-year-olds who was using AI, and they're all using it, whether they should be or not. And I think there's a risk that if we don't engage with that in schools with pupils, and some pupils miss out on that, they're going to be at a disadvantage when they go into the workforce, and they're probably still going to be using that technology but not necessarily using it safely. And so I think there's also a sort of exclusion in that sense of making sure that that's part of our sort of education of young people, so that regardless of where they are in the country or where they are in the world, they're learning to use that safely and learning to use that effectively, because it is going to be part of life. I think we're past the point where we can deny that that's going to be sort of part of their experience.
Thanks so much for all the presentations. It was very interesting. I have a question that's two parts. So one of the things I think about a lot is what we can do with the value that we gain in terms of operational efficiency when we deploy AI, and whether that is time, whether that is resources. And so the first part of my question is, where do you think in both in health and education that we can spend that value that we get from making processes more efficient with AI? Should that, for example, be in more face-to-face time with the patient? Should that be in extra research? And then second to that, how do we make sure that that is where we spend the extra time, for example, that we gain with AI?
To take the question on health first, perhaps?
Start maybe, and then I think in health, I fear that we're not going to get a huge amount of added value, just given the demands that we see coming up. I think we're sort of at a tipping point where actually we're seeing healthcare outcomes worsening in some countries, life expectancy. I think with the sort of the population surges, what I hope I would be able to see is healthcare equally distributed across the world, so that people do have access to healthcare. So I think we're not going to get a lot of free time. We're going to be able to hopefully manage the tsunami that our healthcare systems are facing globally, so that people do have equal access to good outcomes. But maybe that's a bit depressing.
Yeah, I don't have much more to say. So from a health perspective, as you said, there's 15 million deficit of health workers, 3 million across the OECD. So we know there is this massive deficit, but when you have time, I think one of the more poignant things that you got is simply, as I said this before, patients will be able to meaningfully engage with the providers. They're not looking at the back of a screen, because I don't know, for many people, their experience in doctor visits is literally the doctor is typing at a keyboard. And so there will be more direct contact communication, which will foster more trust between the two and ideally lead to better health outcomes. Now, those better health outcomes are measured in years. They're not something that we're going to get productivity gains today. The latest estimates I saw, we're only expecting a 6% productivity gain due to AI in health. So it's small, but it is somewhat. But I think the more palpable thing is reduced burnout, increased patient experience, increased provider experience, which in turn turns into better health outcomes in the long run. And also the demand isn't going down. The demands for multi-chronic conditions are just going up. And we know that we have this demographic time bomb upon us. So how do we address that? And that's where a lot of the time and energies are going to be invested in going forward, dealing with our chronic waiting list, for example, among others.
I think I'm going to echo the same message about not necessarily using the time for something else, but prior to this role, I was working in a school as a head teacher, and I was working 16 hours a day, which is an unsustainable sort of, work-life balance for someone working in education. We've got sort of two issues in education at the moment. The first is that not enough people want to stay being teachers, because it's really sort of exhausting and full on, and you're expected to do lots of different things and not necessarily be able to do them all very well. And then secondly, there's sort of big funding cuts affecting schools. It's the first time in my life that I have a friend that's a teacher that's been made redundant. redundant, and where we've got teaching assistants being made redundant. And so schools are under sort of huge financial pressure to make cost savings as well. And so I think in reality, the efficiencies are just going to sort of translate to teachers staying in the classroom and being able to manage the already unmanageable workload. I think the place you might get sort of additional gains is in all the things that you wish that you could do as a teacher, but are at the bottom of your to-do list, and so you never get to. So that could be things like making more personalised sort of resources for pupils that had additional needs. It might be going and having that conversation with a kid that you've been meaning to have all week and you haven't got around to doing it because you've been sorting out 100 other things. But I think the reality is we're not going to get this massive change in sort of education. It's going to be enabling it to survive and enabling it to keep sort of going in the right direction rather than necessarily sort of leaps and bounds forward.
Thank you. Diane, you had a question?
Got two actually. For Hannah-Beth specifically, do the EdTech providers mind that there's this wonderful free resource provided by public money? And more generally, there seems to be an interesting tension in discussion. Eric, you gave us this really striking thought about trusting the public by pushing the work to them, as in other sectors. And we've been talking about, inclusion and responding to people's needs, but at the same time, just making it work for them. And it reminded me of a debate in competition policy about, we must give consumers more information and let them choose between the different services they want, so they can specify exactly what they get, versus actually consumers don't want to spend time comparing energy tariffs. They just want the market to work for them. And I wonder if I'm over-interpreting or if you think there is a tension there.
The first one for me, I guess, there's like a challenge, I think, for the government to decide whether they want to make things sort of freely accessible for people. That might be resources, or it might be an AI tool, etc. The funding that we've received was to experiment in that space and sort of look at how we could use it. And one of the sort of stipulations of that was that we would be open source and that we would share everything that we were learning along the way. The government's also just put quite a lot of money into the Catalyst Fund. And the content store is aimed at sort of bringing together lots of different resources that can be used by lots of other EdTech providers. So that's things like exam questions, specifications, content from Oak, for example, that other organisations can use to innovate. And they've also sort of given some funding to, I think, 16 different organisations that are startups that are working in the assessment space, sort of designing assessment tools for use in schools. And they've given them some initial funding to go and experiment in that space and sort of hopefully surge some innovation in that area. But I think that's probably a decision sort of at a government level as to whether they wanted to do that or not. For us, the advantage is it means that there's no sort of barrier to people being able to access the content and the resources. Our mission's all about sort of serving disadvantage and making sure that everyone has access to really high quality curriculum. And I think that's really challenging to do if there isn't a sort of free option for people to make use of.
And I'll talk about some of the other things. So there was a study that was done in Canada where they asked the public, what do you expect of the health system to be doing, especially around your data and data use, especially with new technologies. And out of 93 different statements, there was full consensus on 3 items. I expect my data to be used to benefit me amongst my circle of care. I expect my data to be used by publicly funded researchers to cure disease. I expect my data to be used to improve the health and safety of the overall system for the community. Those are pretty powerful. And similarly, there was, I believe that some of the work from the French Patient Assembly, they asked them, what type of services do you want to have more control of? Things like scheduling came to the top of the list. So that's where I think that there is potentially some tension there, but I think fundamentally, if we ask the public it, and there are some services like scheduling, for example, that do not make sense at a system level to be a competitive resource. And this goes back to my point around co-opetition. What are the things that should be commoditized across the system, should just be a service that is offered? And what are the things that are logical for different institutions to be competing on. And I think that we as policymakers need to be having conscious decisions about what is commoditized and what is competitive.
The only thing I'd just add to that is I was involved in a project many years ago on how to stop any wait times one winter very practically. What could you do in 6 months? And one of those was to allow the 111, which is our national call, to then schedule an appointment with the GP for the patient while they were on the call. And the technology existed, the things, but actually it was the doctors that said, no, we want to control the scheduling. We want to schedule patients when we want to see them. We want to re-triage them and put them where we want. So I think there is a fundamental question in health about how much you do want, particularly to go over to the patient. And I think if we were more patient-centered and understood some of the and really focused on outcomes, we would see a lot of this. I think at the end of the day, I don't think there's a tension. I think different people want different things. Some people will want the AI tool or whatever to tell them their diagnosis. They'll know it's factually correct, and that's it. Someone else will actually want to understand why and have all the questions and be able to dig into the choices and to research it for themselves and to be able to dig into it. And some other people will really want to have a person there who explains it and effectively makes the choice for them. So I think it's different. I think there isn't a tension. I think we need to have different solutions for different people depending on what they want.
So I'm going to say that I think there is a version of this conversation where that tension is real. And it's a version of that conversation that becomes a bit big society. So, we're going to withdraw a whole load of resources from the public sector, but we'll have a flourishing of civil engagement that will continue to mean we have access to those public resources and civic activities. There's a version of this conversation that becomes we are abdicating responsibility because we are saying it's going to be up to public dialogue and engagement to decide what type of services we want and how it gets delivered. Whereas actually part of what the public are also telling us at the same time is we want policy and we want regulation that is setting those conditions where we don't have this concentration of market power and where we actually have the structural conditions where innovation benefits everybody. But it's not all about our individual responsibility. There is a collective responsibility and an institutional responsibility here as well.
Thank you. Perhaps let me read some of the questions we have online. I think it's more on the risks side of things. So regarding healthcare, the question is, do you think that the use of AI for self-diagnosis can lead to challenges of doctors' opinions? And similarly, in the education sphere, do you think AI can create issues with misinformation or can push false narratives or disproven analysis of events and principles across topics? Who wants to start? Christine.
I think yes, it can cause people to challenge the doctor's diagnosis. Do I think that's necessarily a bad thing? No, because actually the patient might have given a bit more information or shared a bit more. The patient ultimately does know themselves. I think it's a question of how we handle that and that the doctors have access to the same information, but the public trust is maintained in some way. So I don't think it's a bad thing. So it definitely will. I think one of the challenges, though, is the source of that information. And we also know, so there's this whole idea, well, doctor in the loop or whatever, and then that will prevent safety because the doctors will come to rely on the technology, and it gets to your de-skilling question. And we knew we had an algorithm to detect heart disease in healthcare. You'll know about this, that was designed, and it was run on a one-on-one GP system, 40% of this country, and then it was moved to another GP system, and someone didn't recognize that the data field was different, and it gave the wrong answers of cardiovascular risk for about 15 years, I think it ran for, giving the wrong answer. So I think the challenge is, how are we monitoring these things once they're out there, to go back to that thing, and how are we making sure that actually the challenges and the information that the patients get when they self-diagnose or they do the work for themselves or they enter all the data, which is what we want to do, is actually good and trustworthy? And what are the, your Oak Academy, that you had that brand, how are we going to create those brands that are trusted? And then how are we going to challenge these models, and how we're going to challenge them as doctors when we come to rely on them, and how we're going to detect those errors. And that's what I'm worried about more than a patient challenging me.
Thank you, Anne.
We have to remember that we're not comparing AI to God. We're comparing AI to doctors. Doctors are only accurate 80-odd% of the time. So doctors being challenged are necessarily a bad thing. And frankly, AI is now outperforming some doctors in diagnosis. But at the same time, we do want doctors in the loop. So we need to be helping doctors understand how to work in this new environment and how to interact effectively. I will say there are patients in the US that have taken their diagnosis, asked 3 different LLMs to diagnose them, give them a treatment regime, and then with that, provided that but to the doctor at the next appointment. The doctor appreciated it because the conversation didn't have to start with, tell me about your conditions. The appointment started with, I have these treatments, now what do we do from here? So the person was still engaging the doctor meaningfully, but could have a deeper conversation that started much later in and had a more meaningful conversation overall, which ended up having a better outcome at the end of the day.
I think in a similar vein, I think we're not necessarily comparing AI to a perfect teacher who has sort of, subject knowledge of everything and everything is sort of perfect in the way that they've seen things. Like things change and move on. And I think often we're teaching things that are potentially outdated and we sort of don't move with that time. We've also got a huge number of sort of quite inexperienced teachers in the profession who aren't necessarily sort of subject experts in the area that they're delivering. So I think that there is, in a similar way to the way that you're speaking about, some opportunities to be able to sort of decrease the amount of error or, increase the relevance of what they're talking about. But I do think we need to be really careful that people aren't entirely relying on it and aren't entirely believing the sort of opinions of things. In Oak, we have a few topics that we have blocked Isla from producing because we don't think that the content, we think it's too risky for AI to be producing, and we don't want it to be producing something that could potentially be quite controversial or could potentially be outdated or provide a particular view on something which is going to be potentially upsetting to pupils or to teachers. And so I think we have to sort of also handle that with a bit of care and a bit of caution and choose where we want to use that and where it's really high stakes and not. The final thing on that is like whether it's in something, we've talked a bit about lesson planning, but in something like marking pupils' work is incredibly high stakes, and the risks if you're doing that for sort of summative assessment is really high. And I think there's lots of people sort of looking at that space and about the sort of levels of caution and the amount of sort of safety checks that we need to do in that to make sure that that's not putting pupils at a disadvantage because the AI has sort of done that incorrectly.
Thank you. So this has been a long day already, and I know that some of you had further questions, but I propose that you take the opportunity of the reception to ask your questions to our panelists. Let me thank you all for the great insights you shared. I personally learned a lot. I hope this is the same for the audience.